on Zoom across the country and abroad. All of you conference delegates who are participating in this conference. But also to mention in a special way that, especially for the chairs of this session and for the speakers, that as they speak, they know that we have satellite facilities in 14 places. And these are mainly regional referral hospitals across the country, but also in some hospitals in Kampala, like St. Francis Hospital in Zambia and Mengo Hospital, plus the other regional referral hospitals. And we have at least 12 to 20 people sitting together watching in those places, and they're in satellite facilities, and these are health workers. Also, to add my voice to thank the organizing committee for this conference, and to thank UBC for making it look great yesterday, and we hope today will be even better. Also to thank all the presenters and the speakers of yesterday. Thank you so much. And then to add a voice to thank the presenters for today and the speakers. And it's amazing. We've never had it before for the last conferences that we have had, the 3 of them. This is the 3rd. To find that on the 2nd day for the plenary session, we have all the speakers we invited. It's always been some delegation. It's always been that one of them maybe has not come, but this year has been so special. So I thank you. And then before I say the last thing, I want to thank the leadership of the Uganda Cancer Institute for keeping this partnership going. We are the Palliative Care Association of Uganda, which is completely NGO, civil society. It's a unique opportunity for us to partner with a government entity at the caliber of the Uganda Cancer Institute, and that they respect the partnership and that we roll out as equal. I want to mention what I did yesterday, that as the Palliative Care Association of Uganda, we are a membership organization, and we honor and respect all our members. And in 2019, we introduced an opportunity for people who can contribute more and become life members of PICAO. And we have been receiving one by one. And these individuals pay in 1 million Uganda shillings to commit to participate in the work of PICAO, and they continue to support us. And we are able to do the work because we are completely donor funded and individual contributions to us. So this morning, I thought I would take the show and recognize one of the life members that recently joined and issue a plaque and a badge that I have, which I hope everybody will have by the end of this meeting, to show that this is a commitment that the individual has made. And so I'll do that immediately after introducing to you the chairs of this session. Members online and all of you here, everybody received the conference program, and the conference program has the plenary session that we are on at this time, supposed to start at 11. And when you look at your program, you will find it that the session chairs for this meeting are 2. And one of them is Dr. Andrew Ochero. And I'll not say much. He will speak briefly about himself when he starts chairing. And Dr. Andrew Ochero is already here. The other one is Dr. Jackson Amone. And Dr. Jackson Amone is also here to chair this session. And he will also speak briefly about himself. He's a commissioner in the Ministry of Health. At this moment, allow me to hand over the plaque to Dr. Jackson Amone, who subscribed recently as a life member of PICAO. And then I'll have a picture with him, give him the badge, and I'll take my leave, and the chairs will take over the session. I thank you. Dr. Amone, please receive this. I hope the photo has been taken. Thank you.
Thank you.
You're welcome. In addition, you'll have the badge, and so you chair the meeting with our badge.
Life member.
Thank you so much, and over to Dr. Ochero now.
Good morning, everybody. And it is my great privilege to be co-chair of this session that is composed of eminent persons that shall educate us, shall help us discuss more about palliative care and cancer services in this country. My name's Dr. Andrew Chero. I'm currently a Deputy Chief of Party and Health System Strengthening Advisor at URC, USAID Defeat TB. But more importantly, I'm a palliative care practitioner, enthusiast since 2000, the year 2000, when I first did my training. And I've been an outgoing board chair of the Palliative Care Association of Uganda, and a partial lifetime member. So I know I'll be following Dr. Mone in getting to be a full-time member. Thank you.
Thank you so much, my co-chair, Dr. Andrew Chero. My name is Dr. Jackson Amone. I'm the Commissioner for Clinical Services at the Ministry of Health. I want to thank Uganda Cancer Institute and the Palliative Care Association of Uganda for organizing this third Uganda Conference on Cancer and Palliative Care. The Ministry of Health coordinates all the activities of the palliative care in Uganda, and I'm privileged that it is in my department. And today we are having a very interesting panel of panelists, and we have about 9 topics which are all interesting. And we shall start by having 3 panelists with us here. And I want just to go through the topics which they are going to handle before we bring in another group of panelists. The first will be on health system strengthening and financing for cancer and palliative care. What next? What needs to happen? At some point I will introduce the presenter. The second presentation will be on implication of COVID-19 pandemics on the universal access to palliative care services, the African region. And then the third one will be implications of COVID-19 pandemics on childhood cancers and palliative care in Uganda, diagnosis and treatment. So we will have the panelists, they are already up with us here. We shall invite them one by one. And after they are finished, we shall invite another group so that we continue having until we have the last presenter. So without wasting time, may I at this point invite our first panelist. Is going to give us a talk on health system strengthening and financing for cancer and palliative care. What next? What needs to happen? And this will be given to us by none other than Dr. Charles Ayume, who is the serving member of parliament representing Koboko municipality in West Nile. Is the chair of the Committee on Health in the Parliament of Uganda. He's a medical doctor and a politician. So he combines these two, and he'll tell us what we are going to hear on this. He's a qualified as a doctor in 2004 and became a member of parliament in May 2021. Put your hands together to welcome Dr. Charles Ayume to give his presentation.
Thank you very much, Dr. Jackson. You can use the...
Is this my lifetime badge also? Yes, good morning, viewers. My name is Dr. Charles Ayume, as had been introduced earlier. I'm the Member of Parliament of Koboko and Koboko Municipality, and I'm the Chairperson of the Committee on Health. probably what Dr. Jackson didn't mention is that I've been involved in health systems strengthening for the last 10 years with the Health Monitoring Unit. I worked with the PS of Ministry of Health and traversed the entire country trying to look at different aspects of the health sector and trying to electrocute it back into motion. So I have touched very many areas of the health sector, but one that eluded us was palliative care, and that I must apologize. We thought there were more pressing issues at that time, and we did not think it deserved the attention, and I'll tell you why later, but it was by error. I would want to thank the team, that is UBC, Palliative Care Association of Uganda, Ministry of Health, Uganda Cancer Institute, for inviting me. It's an honor to be here to speak on behalf of the Committee on Health of Parliament. Maybe just to let the viewers that Parliament, of the 4 roles, we are directly linked to palliative care because we appropriate the budget, and we also represent the people. I represent the people of Koboko. I also represent, I have a stake in my profession, which is a medical profession, and like I said, we also appropriate the budget. So we are directly involved, and this is a very key area for us. Now, and we also legislate. What we are trying to achieve in terms of palliation, palliative care cannot be done if we do not have an enabling legislative framework in place. And I must say that the advocacy comes at a time when we are trying to formulate new policies, new laws, and in particular, the policy on palliative care seems to have stagnated somewhere, and good enough we have a representation of Ministry of Health there in amidst us. But I must say, in my term of office as chair of the Parliamentary Committee on Health, we pledge to fast track some of these policies and laws, because we cannot implement if we do not have enabling laws. And one of them, last week we had a presentation by Uganda Health Consumers Organization on patients' rights. And patients have a right to health care, but as a policy, we try and push for the policy on palliative care. There's an interlink between the patient's rights to health care and also the policy on palliative care. So this policy, pushing for this policy comes at a time when the Parliamentary Committee on Health is also chasing other policies, including the National Health Insurance Scheme. How does palliative care fit into the scheme? At the design of the National Health Insurance Bill was a huge component of palliative care. So those are some of the things that as a committee we are trying to unpack to ensure that it is holistic. But then again, I must say that we should not look at palliative care in its silo. Let us have an integrated multi-sectoral approach. Let it be embedded into the training curriculum of medical schools, of nursing schools, of schools of allied health professions, so that, because if you went and just did random sampling amongst, let's say, nurses, when you go to them, immediately they tell you that patient is for hospice. And this is what we see, this is what I saw in our training. And when there was a patient who needed palliative care, first thing that came in your head was cancer. But there is a lot beyond palliative care than looking at it from the aspect of cancer. We thank Uganda Cancer Institute for being the vanguard, for taking the mantle. But again, like I said, there is more beyond palliative care than cancer. Of course, one of the biggest drivers of why we go to seek medical services is pain. And then palliative care is also associated with pain, but there are issues like hope, there are issues like anxiety, there are issues like physical disability. And there are so many other issues. We have mainly focused on the aspect of pain, but that's why I'm saying let us look at it in a multi-sectoral approach and integrate it into the normal health care. Let's go backwards a bit. If we are to have an enabling law and successfully pass it, we'll be wasting our time if we don't go back to where is the factory process, where are we producing the people who are going to take care, the foot soldiers, the people who are going to be at the front line. I'm very happy to say that over the last couple of years, there's been improvement in sorry about that. There's been improvement in human resources for health, but we have also not seen government plow the products, the trained products, back into the regular human resource system of Ministry of Health. And again, I would pledge to support on behalf of the Parliamentary Committee on Health to ensure that as we review the human resource structure, we have these cadres at various levels, at least cascade to the level of Health Center 4. Because we should not only look at palliative care as the clinical aspect, where it stops at the National Referral Hospital, at Uganda Cancer Institute, but it should go down to regional level hospital, general hospitals, and up to at least Health Center 4. But then we also need to have the community aspect. Because I remember when I was in medical school, hospice used to have outreaches and go out, but we should look at palliative care beyond donors and integrate it into part of our clinical care. And again, I pledge that as a Parliamentary Committee on Health, in our engagements with Ministry of Health, we shall try and advocate for this. I am meant to hear that in the structure of Ministry of Health, there's a position for Commissioner for Palliative Care, and Ministry of Health will let us know how far they have gone in terms of recruitment. But it's important that also at Regional Referral Hospital, we have the space for running palliative care clinics. We have consultants, just as we have a consultant on obs-gyn, surgery, pediatrics. Same to general hospitals and down to the Health Center 4s. So again, it's very important that from the health system strengthening perspective, we have the human resource of health integrated into the system, but also most importantly, the community system. We should not only look at the clinical aspect, but how do we sensitize the community? Because palliative care is also beyond just the patient. We need to look at families, we need to look at societies, we need to look at the communities. The people we represent, when we go back to the issue of cancer, some people may say cancer is on the increase, but then again, I may argue it from the other point that we are detecting it early. The diagnostics are in place. There's better sensitization. There's better community awareness. What was deemed as witchcraft, what was deemed as so many myths are coming out, and we're able to tease these people out from the community. So I also want to see the same approach with palliative care, where people are not condemned to death, where issues of stigmatization are decreased, and we're able to go down to sensitize the community better. Now, there are so many bills that are before the parliamentary committee, and as you're aware that the Speaker recently, the Speaker of Parliament, tasked that most bills that were not finished by the 10th Parliament will come back, and then we start the entire process of reviewing them and of rebuilding them. And this is the best time that in case there were any other issues that were not put into the policy, this would be the very good time for us to have an interface, Palliative Care Association of Uganda, Uganda Cancer Institute. We are ready to have talks so that we can have a policy that is quite rich and that we can pass so that we implement and integrate it into policy. I hope I'm audible enough. Yes, on the issue of financing, we appropriate resources. We shall have an interface during the time for passing of the budget. So it would be very important that as Uganda Cancer Institute comes forward, we shall also interface with Palliative Care Association of Uganda to ensure that some of these issues like the medicines, the essential palliative care package is increased, because sometimes when we are doing budget cuts, those are the low-hanging fruits that suffer collateral damage. We have seen that with psychiatry services during the COVID pandemic. All the psychiatric clinics at regional level hospital were repurposed into COVID treatment isolation centers, and treatment centers. So we are saying, can we step forward and protect some of these areas that when we sit in boardrooms, we do not seem to think they matter a lot, like mental health. Right now, they are operating in corridors. Palliative care, these are places where budgets will be affected, will be cut, especially now that there are budget cuts. But can we stand firm? And it's good that we have people to advocate. And I pledge support as chairperson of the Committee on Health that we shall ensure that instead of budget cuts on areas like palliative care, we shall step it up. We have seen the path and journey of cancer. When 10 years ago they were operating a paltry budget of 333 million, now I'm proud to say they're operating a budget in excess of 57 billion shillings. So let us not lose hope. Colleagues, ladies and gentlemen, the future is bright for palliative care in Uganda. Thank you.
Thank you, Honorable Dr. Charles Ayume. The next speaker is Dr. Emmanuel Luyirika. Just a brief about him. He's going to talk about implications of COVID-19 pandemic on universal access to palliative care services. And that is the Africa region perspective. As he gets to the podium, I'll just mention a little about him. He has been the executive director of the African Palliative Care Association since August of 2012. And he's also a board member of the Worldwide Hospice and Palliative Care Alliance and a commissioner on the Lancet Commission on Global Access to Palliative Care and Pain medicines. He has a very long list of, he has quite a lot of experience working in South Africa and in Uganda as well. And I think I will just be that brief for now. So you're most welcome, Dr. Luyirika.
Thank you very much, Dr. Ochero, and I would like to take this opportunity to thank the colleagues at the Uganda Cancer Institute, Dr. Rem and your team, and Mark and the team at Palliative Care Association of Uganda and Ministry of Health for involving the African Palliative Care Association in the Uganda conference. We are thankful that you are making progress in the issues that affect patients with cancer and palliative care. I'm going to make the presentation on implications of COVID-19 pandemic on universal access to palliative care services, focusing on the Africa region. I want to start by bringing to you the pre-COVID-19 state of palliative care in Africa. If you look at the map from the African Palliative Care Atlas, which was done in 2017, Uganda had a number of achievements. One, we are part of the BELT, Southern Eastern Africa region, which has documents, which has access to policy frameworks, palliative care found in some aspects of their national policies. And that has been consistent in terms of the Eastern Africa and the Southern Africa region. The next map shows the number of palliative care services in terms of the top countries in Africa with palliative care services. And Uganda, in 2017, Uganda came on top with 229, and South Africa following with 160. And again, all the other countries within the Eastern and Southern African belt. And then you go to palliative care services per million inhabitants. Again, Uganda was number 2 in that map, which again is a credit to you as Uganda. It's only Swaziland which beat Uganda at that stage, and it's because Swaziland was a small population country. Now, fast forward in 2020, when we produced the Global Atlas on Palliative Care in December 2020. Prior to that, in 2015, Uganda was the only African country in the league of countries like the US and UK in terms of integration of palliative care services. But in 2020, Malawi and Swaziland, or Eswatini, dethroned Uganda because of the investments they made. And so Uganda went to Group 4A, and Malawi and Swaziland, or Eswatini, in Group 4B, which is the top group in terms of integration of palliative care into the national health system. Then, just before COVID started, actually after COVID started in April 2020, the African Palliative Care Association, working with the King's College London in the UK, we did a survey in Africa to look at how prepared the African palliative care services and systems were as we were going into the pandemic. The objective was to evaluate the preparedness and capacity of African palliative care services to respond to COVID-19 pandemic. We did a cross-sectional online survey guided by the 2005 International Health Regulations, and we went out to 166 palliative care, the African Palliative Care Association member institutions and partners. And then we did an analysis of that. Of those, we got 83 returning the results of the survey from 21 countries, and 63% had at least one procedure for the case management of COVID-19 or another infectious disease, which was a good thing at that moment. But I think most of those countries are countries which had also experienced maybe Ebola or some other infectious disease. However, the respondents reported concerns over accessing running water, soap, and disinfectants. That is 43% for water, 42% for soap, and 59% for sanitizers or disinfecting products. And they were also concerned, 52% were concerned about the safety and security of their staff. So that was the situation in April 2020. Now, we also discovered that 41% did not have any resources or reserves to make available protective equipment, personal protective equipment. That again shows you how bare most of these organizations were. 41% of them had no access. 80% reported having the capacity to use technology instead of face-to-face meetings. And that was a good sign that 80% of those members across Africa could deliver some of the services online instead of physically interfacing with the patients. 52% reported having palliative care protocols for symptom management and psychological support that could be shared with non-specialist staff in other healthcare settings, because as the pandemic evolved, then other people had to get involved in managing patients. And so it was encouraging to see that at least 52% had access to those protocols. Now, the other issue that came up, of course, is that lockdowns resulted into limited access to the services, and many of the COVID-19 and non-COVID-19 patients, whether they had cancer or kidney disease but needed palliative care, got isolated once the lockdowns were declared. And that was a major issue, both for the COVID-19 patients and the non-COVID-19 patients. And we shall just take the example of South Africa in terms of what the impact of that has been on palliative care delivery. Hospices in South Africa care for over 150,000 patients a year. Now, when COVID broke out, since the outbreak of COVID-19, 14 of those have closed. You saw the services I showed you at the beginning. I think there were about 160. 14 of those have closed because of the impact of the pandemic, no access to adequate financing, and therefore that was bad, despite the fact that the need was increasing. The need due to COVID, the need due to the non-communicable diseases like cancer, but hospices were closing because they had no money. The other issue is that in Kenya, there was some progress. Even as we were having the issue of COVID, work was going on, and in Kenya we worked with them because we at the ministers' conference meeting we had in Kigali in 2019, they adopted a package, a basic palliative care package for inclusion in UHC. So we managed to cost that using the Kenyan system and setting a platform which other countries like Uganda or any other African country can use to cost the services in their own facilities. And that package includes things like personnel, it includes patient user devices, it includes medicines, it includes other services that are needed by palliative care patients like psychosocial support, spiritual care, and others. So that package, we were able to do that in Kenya. However, in Kenya, they also had challenges due to the pandemic because some of the oncology outpatient services were closed because of the lockdowns, and so they were also affected just like we were. And then patients had no access. Even where the services were open, patients had no transport to get to the services. In Uganda, we had a similar issue where I think they arranged some ambulance service in the city, but again, that was not inclusive enough, and therefore calling for better preparation in future to ensure that we have those services available so that cancer patients and other patients do not miss their appointments, those who cannot be reached by the other mobile teams. The other development that was happening on the continent is the City Cancer Challenge. The African Palliative Care Association offers the technical side of palliative care to the City Cancer Challenge. City Cancer Challenge used to be part of the Union for International Cancer Control based in Geneva, and it became an independent entity. And the African Palliative Care Association handles the palliative care arm, part of the technical support for the cities. So currently we are doing Kumasi and Kigali, and in Kumasi we were able to work with them, and they have done a number of things. For example, they have launched their cancer registry, and they have also done the technical documents for the City Cancer Challenge for palliative care and the other components. Then you go to DRC. Since we are looking at Africa, DRC, again, is another country where they have challenges with access to both cancer care and palliative care. And we were involved with the support of the United Nations Office on Drug and Crime and the Belgian government. They funded a project where we are supporting them to develop the systems, educate staff, train them, mentor them, improve access to controlled medicines, not only for palliative care in cancer, but also controlled medicines for other conditions, in anesthesia, in mental health, and in other aspects of medical care. And we were able to do that, and it's still going. The training happened, the assessment of what was happening. If you go to DRC, at the time when we went, a bottle of morphine, which is given free of charge here in Uganda, it costs a patient $10, 10 US dollars, to get that single bottle where they can get it. And they have no access to most of the other medicines. So that project is helping them to improve on that. And that has been happening throughout this COVID lockdown, and even the training supported on an eco platform is continuing for staff from 10 hospitals in DRC. Now going on to funding, palliative care funding in Africa, many of the governments in Africa, when they were hit by the crisis, they moved resources away from most of the other things. We've just heard the Honorable talk about cuts. And the money left cancer and left HIV and some of the other non-communicable diseases and went to COVID-19. In addition, the lockdowns disrupted access to medicines, again, in most of those countries. And then you had NGO funders. Most of the hospices, as you've heard, apart from countries like Rwanda, I think, and Swaziland and Botswana. But in most of these other countries, a lot of the palliative care funding is done by NGOs. And these NGOs were hit heavily. So we were able to work, because the African Palliative Care Association gives grants to palliative care providers, about 20 every year. So then we worked with the financiers of those grants, so that the hospices could change their packaging from what they had set out to do to then address both palliative care but also the issues that had been raised by COVID-19. So that flexibility was good for the countries and the organizations that we funded. Now, as I come to the end, in all these challenges we had for palliative care in Africa, the lack of access to adequate cancer and palliative care services, the lockdowns, we had the tyranny of misinformation in Africa. A major problem of misinformation that has increased the vulnerability of patients, cancer patients, non-cancer patients. That misinformation has increased their vulnerability. And it has also highlighted the need of packaging information in the languages that patients understand. I know we can either have them in English or French in countries that speak French, but it highlighted the need to have those packages in local languages. We have major languages in Uganda, for example. We could package in Runyankore, Ruchiga, Runyoro, Rutoro, Luganda, Ateso, Luo, Akarimojong, Lugbara. That kind of packaging of information will be very critical in addressing the tyranny of misinformation in this era. And it did not only affect palliative care and cancer patients, but it has also come to affect access to COVID vaccination. And so, again, that's another area that we need to look at. As we move forward, we would like to request governments to, Uganda government included, to increase the investment into, to increase and ring-fence funding for cancer and palliative care. Just like it's like we talked with the Honorable Member of Parliament. That is critical, to ring-fence that money for cancer and palliative care, so that when there are changes, that money is not affected but should actually be increased. We also need to, the COVID-19 lockdowns demonstrated the need to decentralize cancer services as well as palliative care services, and I know for Uganda you're already doing that, and that is fantastic. And we'll get, I know for example next month we'll be having a delegation of cancer and palliative care teams from the Ministry of Health in DRC to visit Uganda to look at how our cancer services are set up, how our palliative care services are set up, how our access to oral morphine is arranged in the country. It should have happened in February, but because of the lockdown, in July, but because of the lockdown, it was postponed. So Uganda has very good practices which can be picked by other countries, and even when those countries come and pick those best practices from us, we should not lose the leadership that we have already. My last point again is on the packaging of information. As we work in cancer and as we work in HIV, it is important for us to have information in languages that people understand. I know there are information packages that were funded by the American Cancer Society, I think, at some stage, but we need to strengthen that and make sure that we have standard packages for the patients and their families and the general population in the local language. Majority of the Ugandans do not speak English, but they speak their local languages. And that has been a challenge everywhere when COVID came, and it affected not only cancer and palliative care services, but all the other services. As I end, I want to thank the Uganda Cancer Institute, Ministry of Health, Palliative Care Association of Uganda, and the other partners that we work with to fund palliative care across Africa and in Uganda. And Uganda, we want to thank you for hosting the palliative care, the African Palliative Care Association in Uganda, because our offices are here in Uganda, and we will always be your reliable partners both for cancer and palliative care. Thank you very much.
Thank you so much, Dr. Emmanuel, and we are privileged that we are hosting the African Palliative Care Association in Uganda, and that's why we can get the information very easily. All the information which we are receiving, I think we shall make sure we handle them, including what the Honorable Chair for the Committee of Health in Parliament has said. The limiting factor has been the policy, which I think the Ministry of Health is working so much on. Moving on, we have our third presenter on implication of COVID-19 pandemic on childhood cancer and palliative care in Uganda, the diagnosis and treatment. And who is going to, the person going to give us is Dr. Balagade Joyce. Balagade Joyce is a consultant of pediatrics oncology, and she heads the children's department in Uganda Cancer Institute. She is the incoming continental president of the International Society of Pediatrics Oncologists. That is the SIOP Africa. She has more than 10 years experience in the field and is passionate advocate for the childhood cancer in developing countries, and she believes that every child with cancer deserves the best treatment possible within the confines of the available resources. She holds a master's degree in pediatrics and child health from Makerere University and a certificate of medical oncology from the University of Cape Town. Join me to welcome Dr. Joyce to give us a presentation.
Good morning, everyone. Protocol observed. There are very many important people here, and I'm very pleased and want to thank the organizers of the conference for considering children. Many times children are a very silent, lost voice in many things, but at such a prestigious conference, the third one of its kind, I'm very pleased that children have a voice. So I'm tasked with speaking on COVID-19 pandemic, childhood cancer and palliative care in Uganda, its effect on diagnostics and treatment. So the first slide I wanted to talk about is published on the website for the United Nations, and it says to us very clearly that childhood cancer has been affected on our continent, and there are more than 30,000 children in sub-Saharan Africa that have been affected by this pandemic. primarily because of the effects that the individual governments and health systems have put into place to curb the pandemic. But children have been a casualty of these measures, especially children with cancer. And this has emerged because non-communicable diseases, especially cancer, do not receive or have been affected by this pandemic. And this has happened on top of the fact that even without the pandemic, non-communicable diseases, especially cancer in children, do not receive the requisite attention that they deserve. This has also happened in the background of the fact that many of the African governments, Uganda included, have put into place measures that have curbed, for the most part, the danger posed by communicable diseases like malaria and TB. They are robust control programs. And so now cancer is emerging as a threat to mortality of our children. So what are the challenges that have been posed by COVID in delivery of cancer care? I have put some of them out there. I know all of us know them, but it is important to crystallize them here for all of us. There's been difficulty in accessing cancer treatment services in Uganda, especially at the National Cancer Institute, but also at the regional cancer centers, of which the most robust one is Mbarara Regional Cancer Center. Why? Because of the national lockdown. We all know what the national lockdown entailed. There was grounding of public transportation, and families and guardians died, and those who didn't die lost their livelihoods and so forth. We know that cancer in Uganda is mostly amongst the rural population, and yet almost 80% of Uganda is rural. So the most affected people live in rural areas and are unable to access cancer treatment services during a national lockdown. But from the perspective of the Uganda Cancer Institute, we experienced challenges because more than half of our clinical teams were affected, more so during the second wave. And some of our services were severely de-escalated. For example, surgery. And this is because of the greater risk they were exposed to by COVID. And this affected us as the Cancer Institute in delivering optimum care to the children. So COVID-19 is threatening to reverse the gains that we have so far made in managing childhood cancer in the country. I want to mention that children are vulnerable already because they depend on their parents and their guardians to come to hospital. So if their parents and their guardians are dead or they are incapacitated, then children are affected. So even in this pandemic, even though children per se don't have as high mortality rates as we see in adults, they are indirectly affected because of what is happening amongst the adult population because of COVID. And so you can see there what happened to us in Uganda. And I'm using the Uganda Cancer Institute as a prototype because we have the only comprehensive children's cancer treatment center at the Uganda Cancer Institute. So we experienced reduction in the number of children that present to us from our projections. And this was experienced institution-wide, but also among the children, and I mentioned the reasons why. We had the national lockdown, and we had parents and guardians passing away. Secondly, we had escalation in the stage of disease that came to us. So it is those children that were really very sick and had advanced disease that presented to us at the Cancer Treatment Center. This is very important to us because already we have about 70% of our children presenting with stage 3 and 4 disease. This is worrisome because even though childhood cancer is highly curable, the high curability is a function of presenting with disease that is not so advanced. Even though if you compare children and adults, children are easier to treat with cure in advanced stages of disease, it still affects the outcome. And it still requires more treatment modalities that are more toxic. So we experienced this because children were coming to us with advanced disease. They had been referred further on, but they could not access the cancer treatment center. And so that was a big, big challenge to us. We also experienced poor adherence to therapy. So one of the things that enables us to treat with cure as an endpoint is adherence to treatment. And so we ended up having children who are away for a period of time, which in scientific terms is called treatment abandonment. I know a lot of our people don't like that term because it connotes that parents and guardians don't care about their children and they've abandoned. But this is a scientific term in our circles that means failure to return to treatment on your appointed date for 4 weeks or more. So this happened to us. And I can give an example of one of the eye cancers called retinoblastoma. It's highly, highly curable. However, of the 10 children that we enrolled, and the Cancer Treatment Center has now a budding treatment center of excellence for retinoblastoma. And so the children who have retinoblastoma are very tightly marked and called for appointments. But of the 10 children that we had enrolled so far, where their chemotherapy is available for free, it didn't stock out at all, where there's a dedicated clinic and they are seen upon arrival, they are anticipated, where radiotherapy is now available. So all the ingredients were there, but only one of our children actually adhered to therapy. So COVID affected us, even amongst the curable diseases. I wanted to mention and to bring this closer to home using some figures in the next slide. In the first wave of the pandemic, we actually had only one child that tested positive for COVID, and that child actually passed away. But you can see on that bar graph what we experienced in the second wave between June and July and August. So at the start of the second wave, you can see our numbers went up. And these are children that we were testing on suspicion. So there was no screening of everybody. But the children who were symptomatic and their guardians, you can see what happened to us. And 50% of those children passed away. And another 25% have long COVID. They're alive, but they have long COVID symptoms. What does this mean? It means that COVID is actually affecting the outcomes of our children, because those who test positive actually are put off of therapy, because the second wave, the Delta variant, is quite aggressive, even though this didn't come out very strongly amongst the children. So they could not continue curative therapy, even if they didn't get admitted onto the isolation site. So interruption of treatment in that regard is going to affect cure. A lot of those children were leukemia, and leukemia is one of the cancers that we treat with cure as an endpoint at the Cancer Institute. So I think that the effects of COVID on survival, we are actually going to see them in the next immediate to intermediate term. And the survival gains that we have experienced, which have been 50% right now, for the more common cancers, I think are going to be adversely affected, and it will show itself in our figures. I wanted to mention also in the next slide that services at the Uganda Cancer Institute continued. This was something that people worried about, but we were in a very fortunate position because we have a dedicated cancer treatment site. So unlike other countries in Africa and in the more developed countries where cancer treatment services came to a complete standstill, this also happened in the mental health, as we've been told by the Honorable. Cancer treatment in Uganda actually continued. And we received a lot of calls, people asking us, what have you done about your cancer treatment? So chemotherapy was available throughout. Radiotherapy was available throughout for those who came to the cancer treatment center. Surgery was a little bit affected, but it also continued. So the ingredients were there. Services were not interrupted, even though they were limping when some of our staff were at home. So I wanted to make an appeal. And I wanted to use this podium because we are speaking to an audience that's mostly the ordinary Ugandan person, that despite COVID, childhood cancer is not going to wait. It will not wait for all of us to get on top of the COVID pandemic. Childhood cancer does not wait for COVID-19. And because we treat childhood cancer with cure as an endpoint, it is incumbent upon us to make sure that we continue to do everything it takes, COVID notwithstanding, to make sure that our children get the best care possible, to make sure that we're treating them. We still have a target to meet. COVID is not going away. The WHO has put a challenge out to us in the 2018 WHO GICC resolution, where GICC is the Global Initiative for Childhood Cancer. And we really have a target to achieve an overall survival of 60% by the year 2030. So we have only 10 years to achieve that. Things have become a little bit more challenging because of COVID, but we must achieve that. And so to me, I'm using these 10 minutes to make that appeal and to make sure that at this point I give you some of the things that we need to achieve that. So in Uganda, every year, we have 3,000 children between the ages of 0 and 18 that develop cancer. And this is according to GlobalCan. Only 30% of those present for care, meaning that 70% of those do not present for care. They are dying somewhere. They are not being diagnosed, or they are being misdiagnosed as tuberculosis or brucella or typhoid or some kind of witchcraft. 70% of those are not presenting, even before COVID. So we must not allow COVID to reverse the 30% that we have reached, which is not good, but we can't now go back to 20 or 10. Despite COVID, we must increase the number of children who come into care for curative therapy. We must also, despite COVID, find ways to address the children who are abandoning therapy. Children are vulnerable. They depend on their parents to come. So we must address this. COVID notwithstanding, if we allow ourselves to be paralyzed by COVID, we are going to get none of our children surviving this curable disease. Cure is possible. As Uganda, we stand at 50%. 50% of our children are cured right now at the Uganda Cancer Institute within the resources that are available. We must continue to move to the 60%. Palliative care services have been affected, and I haven't made a distinction because palliative care is part of cancer care. The two are the same. You cannot tease them apart. So we must continue. Cure is possible if we diagnose early. Childhood cancer is different from adult cancer because it's not preventable and it cannot be screened for. So we cannot do something like screen for prostate cancer, screen for breast cancer. Those messages are for adults. In children, we cannot screen, we cannot prevent. We must diagnose early and accurately and treat appropriately. And right now, despite COVID, this appropriate treatment is available at the Uganda Cancer Institute. We have a state-of-the-art pathology service. We can diagnose accurately and treat. And we must adhere to treatment despite COVID. Okay? So, where the question is, has COVID affected the diagnosis? Has COVID affected the treatment? No. Those services are there. What COVID has done is affect access to those services. And the challenge is what are we as Uganda going to do to make sure that access is still possible despite the pandemic? So I have a slide here that was very nicely made by the NCD Alliance on the early warning signs of childhood cancer. I use every opportunity to put them out there because we must suspect early, okay? And then treat at specialized cancer treatment centers, which we now have in the Uganda Cancer Institute, which we now have at Mbarara Regional Cancer Center. We have shared care services with Mbarara, which we now have budding in Arua. At least diagnostic services are available there. And once diagnosis is made with our shared care service, we can do something, which is now starting in Gulu, and which is hopefully going to start in Mbale. The most curable cancers we have are blood cancer, leukemia, kidney cancer, lymph node cancer. And we must address treatment abandonment. So to me, my message is childhood cancer, palliative care services for children cannot wait for the world to control or stop COVID-19. COVID-19 is here to stay. Let us find services, let us find solutions that can enable us to cure our children, to make sure that our children live in dignity with the palliative care services that we have in this country, despite COVID-19. I thank you for listening.
Thank you. Thank you, Dr. Joyce Waragade, for that wonderful presentation that indeed ties up with the discussions that we had prior. The key message is that we need to have centralized specialist services that shall be able to withstand the impact of pandemics like COVID-19. And it ties up with what Dr. Luirika said before, that we need to have, while we have these centralized services, the palliative care really needs to be decentralized as far as possible. And then we, increase or enhance access to these centralized services. And of course, again, what Honorable Charles Ayume did talk about, we need legislation, we need advocacy to enhance, to ring-fence, to help us ring-fence resources for these services, both for cancer and for palliative care. I think this has been a very well tied up discussion, and we are hoping that the audience out there is going to bring out a number of questions. I think you can send your questions through chat and other forms of media that you are able to access right now. And we also hope that the audience here shall be able to come up and give us some more issues to discuss. Dr.
Thank you so much, my colleague, Dr. Andrew. We shall have a short brief break as we allow our participants to take their seats, and we get another set of 3 participants on the podium. Thank you very much.
Hello, welcome back to the second part of this discussion. We had a very lively first session where we discussed about cancer and palliative care and the implications of COVID-19 on these services. We continue our discussions with another 3 panelists, and these include Mrs. Rinti Kintu, Dr. Nixon Nyonzima, and Cindy Sifros, and Dr. Anne Merriman, who shall be joining us from, she's indisposed right now, and shall be joining us through a link to say hello, but then shall continue with the recording. And then we have Mr. Agre, David Chivenge, and Sister Amuge Beatrice. So I hand over to you, co-chair, to introduce the next speaker.
Yeah, thank you so much. We are now going to our 4th presenter, and we are having the presentation from Ms. Rinti Kintu, who is going to take us through strengthening access to pain and relief medication in Africa. What more should the stakeholders do? As he comes on the podium, Rinti is a registered nurse with a bachelor's degree, specialized in oncology, infectious diseases, and in access to health care. She has been working for the last 15 years on access to pain relief, palliative care, and cancer treatment, both in Europe as well as in sub-Saharan Africa. Rinti has a vast experience in improving access to health care, both in rural communities as well as major urban hospitals within Uganda. With both her experience in clinical service as well as policy development, she's able to be the bridge. The gap between patients, health workers, and government institutions. Rinti is the director of Kiwi Development Consultancy and has been working for over the last 5 years as a consultant for the American Cancer Society's Treat the Pain program and the Global Cancer Treatment program. In this capacity, she supports the government and the cancer treatment centers of 12 countries in sub-Saharan Africa to improve access to pain relief and access to cancer treatment. Join me to welcome Rinti on the podium.
Chairpersons, distinguished panelists, the health fraternity, and viewers. My name is Rinti Kintu, consultant to the American Cancer Society, Treat the Pain, and Global Cancer Treatment programs. And although I'm Dutch by birth, I call Uganda my home country. Over the last 10 years, investment from both government and partners did make great improvements into the health sector. And I want to acknowledge the hard work of many people in Uganda into the health sector. The policymakers, the doctors, the nurses, the engineers, and many others. When it comes to access to cancer treatment, Uganda, through the Uganda Cancer Institute and other key players, has made an enormous progress. More patients can be treated despite the insufficient budget, and there is an improved quality of care. If I ever happen to get cancer, I will get my treatment from here, in Uganda, as our specialists are as good as specialists anywhere else in the world. When it comes to access to pain relief, the government, in collaboration with partners, has been leading in morphine production, setting a great example for other African countries, who often visit to benchmark for their production. And more important, we are having affordable pain relief available in Uganda, free of charge for patients, as the government fully funds the costs. Are there challenges? Yes, they are there, more than one. From a larger perspective, there is still a lot of work to do, and we need to realize it takes time, adequate planning and funding to train more health workers and improve systems. You cannot build a radiotherapy bunker in a month, nor can you train doctors and nurses in cancer treatment and palliative care in less than a year. It takes time and patience, and this is understandable. However, for the individual patients and their families, the time it takes to get access to services, the distance they often need to travel, the money they need to spend, it is unacceptable. For them, waiting one more day to access care is a matter between life and death. In cancer, delays in treatment are making a difference in the chances of survival. Dr. Joyce mentioned it already. We are seeing this in the pediatrics, in the children with cancer. For access to pain relief, being able to find a health center with the right medication in stock makes a difference between suffering and often dying in severe pain and agony, or living and dying in peace. As we all know, COVID has taken its grip on the world, as if the world stopped turning. Healthcare was greatly impacted. All eyes turned on the healthcare sector. Doctors and nurses are every day risking their lives for people with a deadly infectious disease. An already compromised health budget got more constrained, and other diseases, including cancer and palliative care, were forgotten. COVID took over the world, and the world forgot people suffering from other diseases. There were no beds anymore for people needing surgery for cancer. There were limited drugs available in rural areas due to the lockdown restrictions. People died from their homes in fear to seek health care. This was happening and is still happening today in many places, including Uganda. But other diseases are not less deadly, less impairing, or less important than COVID-19. Finding the balance between the currently neglected diseases and COVID-19, and in the future other epidemics which we might be facing, remains a challenge. I was asked the question, what more can stakeholders do? There is not a simple answer to this, but when I look back to the last 2 years, I see that the success or the failure to access care highly depends on the individuals, their leadership, their motivation, and often their financial resources. Some centers prepared themselves well. They saw the pandemic unfolding in the world and prepared themselves by planning ahead and stocking drugs sufficiently. Though with challenges, they were able to ensure continuity of care and ensured pain relief for their patients. Other centers did not take it serious initially. What happens in the rest of the world does not have to come to Uganda. And during the first lockdown, then there was the cry on how to access the drugs and how to access the patients. Individual leadership has been on the forefront of palliative care ever since it was recognized in Uganda and Africa at large. It's a great thing to see individuals being so passionate about their patients, about care and the development of care. But at the same time, it is a very vulnerable situation. Pain relief or palliative care are not the business of a passionate individual. It should be fully institutionalized. Leadership should come from government, not from passionate individuals alone. Uganda has made great strides in this, for which I will recognize the Ministry of Health, by funding the morphine production and the distribution and taking steps to integrate palliative care into the healthcare system. But often their hands are tied as well. Many people do not understand the need for pain relief and the impact of pain on society. Yet pain is a leading symptom for people to seek health care in Uganda, in Africa, and in many other places in the world. There is a need to train many health workers in how to assess and treat pain. These trainings can be done in person, and in this time of COVID, it can also be done virtually, the same as we are doing this conference virtually. There is need to educate the public on the use of medications used for pain relief, that Panadol and ibuprofen are not as harmless as they may sound, and that opioids do not need to be addictive if used by the right patients. The medications used in pain relief are often controversial, and many misconceptions are blocking people in need to access them. Misconceptions such as, you will die when you use morphine, or you might get addicted to them, are stopping health workers from prescribing them and patients from accepting them. There is need for adequate collaboration in legislation, for adequate protection of the health workers and the patients. The laws on how to handle narcotics drugs can be controversial, criminalizing and confusing, leading to patients who do qualify for pain relief to suffer greatly. Uganda has not yet established the universal health coverage, yet it was one of the targets for the Sustainable Development Goals in 2015, which were reaffirmed in 2019 by nations, including Uganda. 20 years ago, in April 2001, the heads of state of the African Union's countries, including Uganda as well, pledged in the Abuja Declaration to allocate at least 15% of their annual budget to improve the health sector. Instead of increasing the health budget over the years, the health budget in Uganda has been decreasing from 9.2% in financial year 2018-2019 to 7.9% in financial year 2019-2020, down to 5.1% in 2020-2021. About 40% of our health budget is donor funded, but I stand to be corrected on these numbers. With the outbreak of COVID, instead of increasing the budget, we kept seeing a decrease in our health budget. Yet civil society and also government have been highly affected by donors decreasing their funding. Less money was allocated by donors towards programs other than COVID-19. This happened worldwide, and it has affected us all, civil society and government alike. It has shown us the vulnerability of our system. Although partnerships are very relevant, and we should strive to collaborate instead of distrust and work against each other, partnerships can also make us vulnerable when we depend so much on it. However, I do see an opportunity here as well for us as Uganda to show our strength and our commitment to a healthy nation. I'm very happy to be here with Honorable Charles, the Chairman of the Committee of Health in the Parliament of Uganda. As you are representing Koboko Municipality, Honorable Member, you are also representing Ugandans in general. And although Uganda has very many relevant priorities, such as stability, industrialization and the like, without a healthy population, Uganda will face instability, less economic productivity and a higher economic burden. People will not be able to work and contribute economically when they are in pain or when they are sick. Relatives are unable to work when they have to move around looking for a health worker or for medicines. The economic burden of an unhealthy healthcare system will greatly affect the economic and sustainable growth of Uganda. If we are to reach Vision 2040, we must invest in the healthcare center. Honourable, I know you have just finished your first 100 days in Parliament, but I urge you and the other leaders of Uganda to honour the pledges made in the past. Increase the health budget and continue to collaborate with all relevant stakeholders to ensure universal health coverage for all Ugandans and to include pain relief, cancer treatment and palliative care into the health system and into universal coverage. Not for us as health workers, but for the patients who don't have the time to wait and for the future of our country. I thank you all.
Thank you, Ms. Kintu, for that passionate appeal. You took the opportunity to advocate to our parliamentarians, and I think that was quite appropriate. and you have indeed brought out the need for the leadership in the land to take more responsibility for providing for cancer and palliative care services. We are in a vulnerable position when we have to depend on individual leadership. I think that was a key phrase that I picked from her discussion. And of course, the fact that we need training, and we can now do it virtually, just as is being done everywhere. And of course, to sensitize the public as well, so that they access these services. Over to the next speaker, who will be Dr. Nixon Nyonzima. Dr. Nixon Nyonzima is a cancer researcher at the Cancer Institute, working on molecular characterization of cancers in sub-Saharan Africa and the development of affordable, low-cost diagnosis for cancers in resource-limited settings. He completed his doctoral studies at the University of Washington, and he's an investigator on several studies seeking to elucidate the molecular profile of breast cancer in sub-Saharan Africa. He's also involved in building capacity for cancer laboratory diagnosis in Uganda. Please welcome Dr. Nyonzima.
Thank you, Chair, for that kind introduction, all protocol observed. I was asked to speak about opportunities for training in cancer and palliative care, but I decided to tweak that and look at training in general and human resources for health in cancer and palliative care. And I wanted to start by saying that cancer is a multidisciplinary disease. You need many specialists to take care of the cancer patient. So these include pathologists, you have nurses, you have the oncologists. Now, when most people think about cancer, the cancer patient, and think of the Uganda Cancer Institute, they think of the nurses and the medical oncologists. But before you actually get to the medical oncologists, you have a whole other team that takes care of the cancer patient. And these specialists are needed at different levels of the health system. I have put together a model cancer care organization. This is from a paper that was published a few years ago. And this model looked at cancer care at different levels. The Uganda Cancer Institute qualifies as a center of excellence. So you have Cancer Institute as a center of excellence. That's the Uganda Cancer Institute at Mulago. And you're looking at it being the regional cancer center or regional center of excellence in cancer care, but also being the regional center of excellence and the center of excellence for Uganda as a country. Now, at the Uganda Cancer Institute at Mulago, we need the whole spectrum of specialists. So we need the pathologists, we need medical oncologists, we need pediatric oncologists, we need hematologists, we need all the specialists that are needed to provide care for the patient. However, at the lower level, when we talk about decentralization of cancer care, we have the 4 regional cancer centers. We need other specialists in Gulu, in Mbarara, in Arua, and in Mbale. Like Dr. Joyce mentioned before, we have Mbarara and Arua already functional, so we need specialists for those levels. And then when you go lower to the district hospitals and the community health centers, you need other specialists, you need educationists, you need nurses who will be able to screen the patients. You need palliative care nurses, oncology nurses that are going to take care of the needs of the patients at that level. And the slide they showed before is just looking at the facilities that the Uganda Cancer Institute has put together at Mulago. So we have medical oncology, we have gyne oncology, you have radiation oncology, as you can see, and we have laboratory. Now, all these facilities need people to run them, need specialists to run them. And when you look at the specialists that we have as a country, you'll be wondering who runs the services in the country. In 2018, we did a study at the Uganda Cancer Institute and actually in the whole country, and we're looking at cancer specialists, and this excludes specialist nurses. But when you look at this study that we did, Uganda had 20 cancer specialists in 2018. And the required number at that time to take care of the patients and the resources we had at that time was 120, giving a shortage of 100 cancer specialists in 2018. Now, over the past 2 years, the patient numbers have grown, so the requirement for the specialists has also grown. And yet, we're not making very many strides in the country. When you look at the map of available specialists in Africa, you see that Uganda in 2015 had just 6 specialists. And if you look at the map, you can see by color coding, the only green country in Africa is actually South Africa, which had sufficient numbers of specialists, as Dr. Yika talked about. And Uganda looks like it's doing well, but when you think about a country of 42 million having 6 oncologists in 2015, then you can imagine that we're actually not doing well. As of 2021, of course, we have changed. There are many more oncologists, but we're still in a dire need of specialists to actually transform cancer care in the country. This is not just for oncologists in the country, but also looking at pathologists is the same. Uganda has 0.68 pathologists per million population, meaning that for every million samples you get, you probably have just half a pathologist to look at this. Now, this impacts on the diagnosis. You have fewer people to look at the specimens. You have delay in diagnosing the cancers, and this delay also translates into when the patients present. When the patients come to the Cancer Institute, they need to have a cancer diagnosis. So we make the diagnosis at the Cancer Institute. And if you make the diagnosis at the Cancer Institute and you have no pathologist, you take off the tissue, and you may have a delay as you wait for the diagnosis to be made. So what are some of the challenges as to why we have these challenges, these problems in human resources for cancer care? So one of them is inadequate infrastructure. And I showed earlier the infrastructure the Cancer Institute is putting in place for cancer care. This is just the first step, that you have the right infrastructure for training and practice. So it doesn't make sense to train a pathologist and you have no functional pathology lab. It doesn't make sense to train a radiation oncologist and the radiation oncology services are not functioning in the country. So the Cancer Institute has put in place some of this infrastructure, and we're training some people, but we need to build better infrastructure and actually maintain some of this infrastructure so that when these people graduate or qualify, there's something for them to work in. The other is lack of specialist training programs. In Africa, and we'll see that later, we have very few specialist training programs in oncology nursing, radiation oncology, and other specialist oncology programs. The other issue, of course, we have as a country, because we have no specialist training programs, we have to train people from abroad. And when you train people from abroad, the cost of training is very high, so you can only train very few people. We had funding from the African Development Bank, and we've been sending our trainees for radiation oncology to South Africa, and I can tell you that was a very expensive venture to send these specialists abroad. But also remember that when you send people for this specialized training, these are already adults, they have finished the undergraduate training, and some of them already have masters, and you want them to go for 5 years to become specialists in another country. There's a risk that they will not come back. There's the cost, but also the risk that you not get enough trainees. And that's the other point, that we don't have enough trainees for some of these specialized training programs because of having sent them abroad. And of course, the training system in Uganda is such that even when you're doing a master's, you're a doctor, you're qualified, you have a master's in medicine, but now you're doing oncology training, you need to pay additional fees to actually qualify for that training or get the training. That keeps out many people. I can go and see my pneumonia, malaria, and I'll get paid. Why do I need to pay more money to become a cancer specialist? And then, of course, we have insufficient funding. I'm happy that Rinti talked about funding and appealed to the member of the chair of the health subcommittee. We need more funding for oncology centers. If the Cancer Institute is to sustain training of all these specialists, we need funding in our training programs, in our cancer research programs, but also in care, to be able to provide a state-of-the-art service to our patients. And then also have lack of enabling policies. In many countries, you don't have policies that recognize super specialized training. Uganda is fortunate that 2 years ago, we had a policy on super specialized training passed by Uganda Medical and Dental Practitioners Council, and that's helping us actually train specialists. But the next level is that when they are trained, there should be some recognition in the system for these specialists. Currently, you're recognized as either a consultant pediatrician, and as the Cancer Institute, we're trying to change that with a new structure, but it needs to be system-wide, that when you have these specialists, they can be recognized in the system. I just wanted to show a table looking at oncology nursing training programs in Africa. And there are currently, if you can see, there are only 14 countries in Africa that have some sort of oncology nursing training program. I'm putting this up because the Commission of Nursing is here, and we're hoping that Uganda is going to become one of these countries that has oncology nursing, specialized oncology nursing programs in Africa. It's a shame that we have a cancer institute that has been existent for 53 years, but we don't have any program to actually train nurses in specialized oncology in this country. And you ask yourself, how shall we build numbers if we don't have a specialized training program here? So what are the opportunities for addressing the challenges in training for cancer and palliative care? So one of them is establishment of local training programs, like I've mentioned, and this can be at cancer centers. The Uganda Cancer Institute is establishing some programs, but also universities can actually set up training programs for cancer and palliative care. And there are some that already exist in this country. We also need to increase funding to cancer training and research. These are complementary to cancer care. So most times people talk about the cancer care aspect, but you cannot have cancer care without cancer training and research. So we need to increase funding to these two activities specifically. And obviously it goes without saying that we need to improve working conditions for our staff to be able to attract them to these disciplines. We need to create the enabling policies that when I become a specialist, I'm not coming in as a medical officer special grade after 15 years of training. There should be some allowance that when I come back as a cancer specialist or palliative care specialist, there's room for me to grow and room for me to occupy. Then, of course, increasing financing for cancer care allows people to actually come back to these centers. And then we need to strengthen the existing training programs. These are some of the programs that we have critical shortages in as a country and where we require additional training. In almost every cancer discipline, we need more people, we need more training, we need more specialists. So that's radiation oncology, oncology nursing, palliative care, cancer biology, cancer research, pain management, intensive care. The beauty is that some of these programs are already in the country, so we just need to support them and strengthen them. The Uganda Cancer Institute, as a way to address some of these challenges, got funding from the African Development Bank, and we have so far trained about 202 specialists in different disciplines. And I just wanted them to display the table looking at the specialists trained at the Uganda Cancer Institute and highlight that the areas where you see large numbers of people trained, those are areas where we have training programs in Uganda, training programs in the country. So when you think about radiation oncology, we have trained 3 people because we had to send them to South Africa. When you think about gynecology, initially we were sending people to South Africa. Now we're able to train them, so the numbers are increasing. Pediatric oncology, the same. But when you look at programs that are in the country like MMed, that's the Master of Medicine, we have supported 45 trainees. Because the programs are in the country, they are cheaper, and we're able to support many more people. And of course, following in this trend, the Uganda Cancer Institute has established currently 3 fellowship training programs in adult hematology and oncology, pediatric hematology and oncology, and then gynecological oncology and hematology. And because we have set up the facilities, we're also setting up training for radiation oncology and oncology nursing, which we hope with the support of the ministry and other stakeholders here, we'll be able to actually move off the ground and attract many Ugandans into this program so that they can service all these regional cancer centers that we're talking about and the lower level facilities that I mentioned in my model cancer care organization. So the other issues we need to strengthen, we need to establish and strengthen local programs. Currently in Uganda, we have, at the Uganda Cancer Institute, we have medical, pediatric, and gynecology. We have pathology in the country, but I wanted to pause and talk about pathology in specifics. Makerere University has a pathology program, Masters of Medicine in Pathology. And when you look, this is a strong program that has been existent for many years. But when you look at the program, majority of the trainees are not Ugandans. So you have people coming from Somalia, from South Sudan, from Kenya to train in this program, but you hardly have any Ugandans that are training in the program. So why do we not have Ugandans in this program that are established locally? The issue is the cost. There's no support both from our government but also from other people to support Ugandans to train in this program. You have people coming from other countries, they are fully supported, but when it comes to graduation, you have one Ugandan out of the 10. And then you continue having the shortage of 0.5 pathologists for every 1 million Ugandans. We have radiology, and Uganda Cancer Institute, in partnership, of course, with other partners, is strengthening our radiology services and would like to continue supporting radiology training in the country. Somebody talked about intensive care and critical care medicine. This also needs to be supported in cancer care and palliative care. We have a lot of needs for these specialists, and we need to support these programs to actually increase capacity for these. Of course, palliative care is also existent in the country through Mulago and hospice and supported by PICAO, but we also need to support the program, have more trainees, and when they graduate, we should have positions for them to actually occupy. Biomedical engineering is also existing in the country. Machines are always breaking down. Can we support our Ugandans to actually become better trainees and make use of these programs? And then we have planned programs, radiation oncology, oncology nursing, and Masters of Nursing. Can we support these programs to get off the ground to increase the number of specialists? There are many challenges. We had a meeting on oncology nursing about 5 years ago. Masters of Nursing in oncology, we also had it about 3 years ago. Up to now, we don't yet have the program. Can we have policies that enable these programs to get off the ground? And again, I'm happy the Commissioner Nursing is here. After the meeting, I'll ask her if we can get these programs started as soon as possible. And I wanted to finish with just the other opportunities that we have for training in the country. And Uganda Cancer Institute is building collaborations, both internal and external, really to enable training. We have partnerships with the NHS in the UK that are supporting radiation oncology. We have Uganda Cancer Institute and the Fred Hatch. We have Makerere University in Mbarara. All these are partnerships that the Institute is building, really to make sure that we train our specialists in high-end areas, then they come back and support Ugandans. And of course, the new planned program, the infrastructure we're building is all to support human resources for health. It's cancer care, but we need to make sure that our staff are working in the right facilities. And as an institute, I mentioned a lot about the need for a structure that accommodates these specialists. We're doing a restructuring to ensure that we have the right positions for our specialists to really make sure that when they qualify, they don't go to Kenya, they don't go to Rwanda, they come back to the Cancer Institute because we have the right position and the right incentive for them to work in this country. And of course, the policies are changing. We hope they change fast enough and allow training in this country. Thank you very much. And I will end with a slide about the team at the Uganda Cancer Institute that providing fantastic care for our patients. Thank you.
Thank you so much, Dr. Niyonzima, for that very elaborate presentation. And members, as you know, the human resource is a key asset in any institution. And that is what the Ministry of Health is also looking at. As you said, now we are emphasizing that the nurses should specialize. So in all the specialties, we need the nurses as the equivalent to the other specialists to be available. We are happy that as we discuss this, the limiting factor of training is usually resources. And as we talk like this, we are advocating for money to be allocated to Ministry of Health so that they give the scholarship for the right people to come and be trained. It is really disheartening when you see many people coming to get the knowledge after graduation. They run away with that knowledge and they leave the places empty. We have a lot of what they call endangered disciplines, and I think oncology is one of them. Members, we need to move ahead. We want to go to our next presenter. Is going to give us a talk on healthcare equity and access to marginalized populations. What are the lesions posed by the COVID-19 pandemics. And this is going to be given to us none other than Mr. Agre David Kibenge, who is the Permanent Secretary of Ministry of Gender. Mr. Agre Kibenge David is an educationist, and he has a lot of interest in public policy, administration, and management. He graduated with a Bachelor of Education and a Master's degree in Public Administration and Management. He has over 25 years of experience in administration, having crossed from teaching into the administrative cadre, with a greater part of his at the Ministry of Education and Sports from 1993 to 2012, and again from 2016 to 2019. He had a brief stint as the Undersecretary at the Ministry of Tourism, Wildlife and Antiquities from February to November 2012, and thereafter the Office of the Prime Minister from November 2012 to November 2016, before returning to the Ministry of Education and Sports, where he served up to August 28, 2019, when he was appointed as the Permanent Secretary and eventually deployed to the Ministry of Gender, Labor and Social Development in September 2020. Join me to welcome Mr. Agre David Kibenge to give us his presentation.
Thank you, Chair, colleagues, the panelists, and those that have been here before me, the participants both in here, those watching on TV and online, ladies and gentlemen. It took quite some convincing for me to be here, because when you look at the subject, cancer and palliative care, and flanked by all the medical personnel, the doctors, for a public policy practitioner, I had to rethink. But when I got here, I've even been comforted more that I'm in the right place. Because when you look at, I was looking at this pamphlet on the recommended essential palliative care package, and within that is psychosocial support interventions that include social support and protection. I felt that it would have been a disservice for me not to be here personally. I was referring to Article 32 of the Constitution, which enjoins the state to take affirmative action in favor of marginalized groups for the purpose of redressing imbalances that exist against them. And in this very perspective, the subject of my presentation, which is healthcare equity, is therefore paramount to ensure that everyone has a fair and just opportunity to be as healthy as possible, irrespective of social or economic status and other considerations. And on our part, a healthy population is an imperative for increased productivity, societal happiness, and socio-economic stability. So this becomes a legitimate concern. But looking at the mandate of the Ministry of Gender, Labor, and Social Development, which I'm privileged to lead at the executive level or technical level, that ministry is mandated to protect and promote the rights of vulnerable populations, address gender inequalities, ensure cultural growth, labor and employment, as well as community mobilization and empowerment. I'm happy that in Dr. Ayume's submission, in Dr. Emmanuel Ruyirika's submissions, they did emphasize the need to reach out to the communities, to sensitize communities, to decrease stigma through awareness. And I think that becomes a very important element in our addressing issues of palliative care. Of course, the ministry focuses on social protection, equality and equity, human rights, culture, suitable working conditions and employment, and the vulnerable groups. And within these are women, the children, the unemployed youth, the internally displaced persons, elderly, and persons with disability. Some people have actually described it as a ministry of the people, because right from childhood, family affairs, up to the elderly stage, that ministry takes responsibility for the welfare of our people. Now, quickly to the impact of the COVID-19 pandemic on the vulnerable populations. Submissions have been made in this direction, and I'll quickly go through this. Fatality due to the COVID-19 pandemic is unevenly distributed among vulnerable populations, as exacerbated by their difficulty to access high-quality public health and medical care. This mostly is attributed to the socio-economic implications from the pandemic and policy responses, such as the lockdown restrictions we've had that inhibit movement when symptoms manifest, or even when they don't. Delay in treatment of underlying chronic illnesses, which may result in an increase in complications and severity of the disease. Inadequate social protection and support to mitigate the impacts of the economic downturn, and rising unemployment, which has pushed more households into poverty. Even when we try to reach out to some groups during the lockdown, you must have heard of the relief package, we had to simply zoom into certain categories of vulnerable people rather than all the deserving vulnerable persons. Primary health care services are presumably free for people suffering from chronic illnesses like cancer, diabetes, HIV, AIDS, but other costs, as you've heard even from previous speakers, inhibit equitable access to these services. And this is in the form of transport, medication, and diagnostics that have soared during the COVID-19 pandemic. Such costs have likely raised the risk of selling personal properties such as land and driving vulnerable groups deeper and deeper into poverty. We've had harrowing experiences that families have had to go through after looking after a patient who ultimately passes on, and you have a bill of not less than 80 million, 100 million to pick. What else are you left with? If you are within the categories of the vulnerable people, first of all, you will not afford that bill. But secondly, if you risked having that patient hospitalized, then you will have nothing left at the end of it all. Majority of Ugandans, including the vulnerable groups, are employed in the informal sector and depend mostly on daily income for survival of their families, with limited or no access to social protection. What are some of the interventions that the ministry has had in place in the area of social care and support services, including the resettlement of abandoned children and street children, the care and protection of children in conflict with the law, and the provision of support to vulnerable children, persons with disabilities, and older persons has been an area of emphasis for the ministry. This has been possible through the collaboration of government with development partners. Stepping up efforts to pay the elderly people aged 80 years and above under the Social Assistance Grant for Empowerment, popularly known as the SAGE program, where we pay a monthly stipend of 25,000. Seemingly little, but they have been happy to receive it when it is delivered. It's our considered opinion, which we think is backed by scientific evidence, that the standard of living of the population is a contributory factor to non-communicable diseases, including cancer. The government, of course, as you've heard, has also been able to reach out youths, 147,286 through the Youth Livelihoods Program, and about 85,336 women through the Uganda Women Empowerment Program with financial and technical support to start income-generating activities. The ministry has also been very instrumental. We took actually the lead in managing the distribution of the COVID relief funds that we concluded recently at the end of the second lockdown. We have a department for occupational safety and health at the ministry, which is responsible for implementation of the Occupational Safety and Health Act of 2006 and its regulations, which provide for the protection of workers, employers, and the general public from all hazards at workplaces, including those that cause or may cause non-communicable diseases, such as the carcinogenic chemicals. And this department has developed an occupational safety and health guidelines for the office work environment that promote the safety and well-being of the workers, occupational health surveillance guidelines and manual for scheduled diseases as frameworks for monitoring workers' health and risks due to hazardous materials and conditions, and a chemical safety database which will be used to manage probable carcinogens at workplaces and public measures such as safe work practices for handling and using chemicals to prevent or reduce the associated risks. What are some of the key lessons in the execution of our mandate? One, the high cost of health care is a major barrier to access to quality health services. The cost of treatment, especially in the ICUs and HDUs in the private facilities, were way beyond the capacity or even some of those classified as rich. And you can imagine how about the vulnerable categories of our population that we are talking about. Two, community services and low health facilities are a critical component of the healthcare system in situations where higher level health facilities are overwhelmed or when people cannot afford the healthcare costs at the facilities. Three, people will always be attracted to the public health facilities on account of cost if the quality of services improves. And I must at this juncture salute government or public health facilities, especially Mulago. There is evidence from people that confirms that you cannot get any better services than from our own public facilities, especially Mulago. Testimonies have been given. And of course, the Cancer Institute. We have Dr. Orem is my friend. We have personal testimonies to give. But we thank you for the standards. And I think was it Mrs. Kintu, who has also testified that if she were to be treated, or any of her people to be treated for cancer, she would rather do it in Uganda than anywhere else in the world. I think that is a statement of approval and acknowledgement of the quality that we have. In the absence of an effective data management system on vulnerable persons, targeting vulnerable persons for support in times of health care and other associated emergencies becomes extremely difficult. That was our experience in managing the relief funds. Of course, in the case of palliative care, in the case of cancer, there are issues of confidentiality in dealing with health of individuals or regulations on data management. So notwithstanding all this, data becomes very important if we are to effectively reach out all the deserving persons. What have been some of government's response measures? And I'll quickly run through these as I conclude. The proposal to establish the National Health Insurance Scheme, though still underway, should help pooling of resources for the benefit of the general population. 2, establishment of functional health center 3s and health center 2s in all sub-counties and parishes respectively, and equipping them with a wide range of basic facilities to handle healthcare needs at the respective levels is something that we should also welcome. Strengthening regulation of the operations of the private health care providers for affordable health services was inevitable, because at some point it looked like healthcare was getting out of reach for an average Ugandan, and especially the vulnerable categories. Developing a national social protection strategy that is intended to increase social protection coverage and make social protection service delivery more shock responsive is a priority we are working on as a ministry. Establishing a functional database for vulnerable persons to ease targeting of vulnerable persons for specific healthcare support and other forms of emergency support is also something we are giving priority attention. Reforms in the NSSF Act to provide for midterm access beside the invalidity benefit, among others, is also a welcome move on the part of government. Promoting health literacy, sensitization to enhance community awareness on disease prevention as opposed to cure through, for example, the village health teams and other interventions is something that we should also welcome. Under the parish, the development model, one of the pillars is on community mobilization, mindset change, and addressing the cross-cutting issues. And the Ministry of Gender, Labour and Social Development is the lead ministry in that regard. So as far as strategies for community mobilization are concerned, we'll be working very closely with all the other ministries, including Ministry of Health, Cancer Institute, and all other stakeholders to make sure that the right messages, I think it was Dr. Luirika who emphasized the packaging of information as a critical element. The experts in packaging information are within the Ministry of Gender, Labour and Social Development. So we commit to work together on this. In conclusion, I'm saying that the battle against the scourge of COVID-19 and other non-communicable diseases is not likely to end anytime soon. It's here with us. This therefore calls upon all of us to consolidate the defenses that have been built and for us to work together for the good of every Ugandan, and in particular the vulnerable categories of our population. Remember, as I did say earlier, that health care is not only an essential service, but a human right. And I think Honorable Ayume, Dr. Ayume did emphasize that. It's a human right. And a healthy population is an imperative for increased productivity, for societal happiness, and sustainable social economic development. I thank you for your kind attention. Thank you, Mr. Kivenge, for a very rich discussion and a reminder that our social development is really pegged on the health of the nation, and therefore a need for equitable health care. We see a great opportunity in the parish model that is being talked a lot currently, we do hope that our services for cancer and palliative care shall take opportunity and have the communities sensitized and the communities helped to access these services. The next speaker, if I am correct, is going to be I don't know, is going to be the I think Sister Muge. We need some guidance on this.
Yes.
We have two speakers who are online.
Yeah. So we have 3 more speakers coming, and I wanted this time to request you to join me to thank these participants who have taken us through these very important presentations, and we could request them to take their seats. Thank you so much for as we have said, we have 1 more presenter who is going to present physically. May I take the opportunity to invite Commissioner Beatrice Amuge to take her seat. And we have other presenters who are going to present to us online. Sit in the middle. So maybe we could start with one person who is online. We shall have the next presenter is going to talk to us about the compassionate care during life-threatening epidemics in Africa. And that is going to be presented to us. It will be a recording, but we'll ask her to make some remarks before the recording is brought. And this is going to be none other than Professor Dr. Ant Merriman. Professor Ant Merriman is the one who introduced palliative care in Uganda in 1993, when she commenced the Hospice Africa Uganda, the model for Hospice Africa, with the vision of palliative care for all in need in Africa. She was key in the foundation of the Palliative Care Association of Uganda, African Palliative Care Association, and Makerere Mulago Palliative Care Unit. She had a huge impact on the introduction and development of palliative care in Singapore. She founded the Home Care, later to become the Hospice Care Association in Singapore, which is one of the best services in the world. Aunt Merriman has spent over 40 years working in Africa, including 10 years, where she served as the missionary doctor in Nigeria. Aunt Merriman is a Nobel Peace Prize nominee, but has won several other awards, and notably is the Presidential Distinguished Service Award for the Iris abroad. Join me to welcome Aunt Merriman to make some few remarks before we can get our recording on our presentation. Aunt Merriman, the floor is yours. You can make your remarks.
Thank you, Dr. Amone. It's been a great joy for me to see how things have developed so quickly. In 28 years, when I came, nobody knew about palliative care, and the senior doctors, many of them, were against it coming in at all. So what you have done is a wonderful job. And this has been done not only by Hospice Africa Uganda, but by those organizations that commenced with us, Palliative Care Association of Uganda and the African Palliative Care Association. Both of them have wonderful leaders and have done wonderful work. And I want to thank them very much before I go any further. But I just want to say, because it wasn't made quite clear, holistic care is the definite component of palliative care, but you can't give it if you haven't got pain control. And none of the African countries had sufficient pain control before we came in. There was 3 countries only that had oral morphine, and now there's 37. And this has happened through the work of Hospice Africa, through the international programs, working with people on the ground, and with APCA, working with governments and with international organizations. So it's a combined thing. And we want to thank you all very much, and particularly the UCI, because they are really now with us on board. Thank you so much.
Of the recording.
Good morning, everybody. It's to greet you from Ireland, where I'm recording this following my recovery from COVID. Yes, I'm one of the lucky ones, so maybe it's good that I've got this particular thing to talk about, because I tried to have compassionate care, but I was isolated. But anyway, that's another story for another day when I've got more time. But here we go now. So to tell you about compassionate care in the next pandemic. What is compassion? What do our patients want when life is threatened? But if we don't know that, how can we give them compassion? Should they be at home or in hospital? Do our decision makers need a heart transplant because they haven't taken the trouble to go out and see the people that they're going to make decisions for? Can we do better next time? Let's see. Let's look at this picture of the Good Samaritan. And here we see a stranger in the country helping one of the Jewish people that has been damaged by robbers. And while he's doing this, the people of the country are so busy doing other things, like our people are busy doing other things. We're on the mobile phones like this guy most of the time. And then after that, the people in the government are rushing to the next meeting to make more decisions about people way in the village who they haven't seen. They haven't been into their homes. Our doctors and nurses are trained in hospitals. They don't actually see where the people are coming from. And that is really very, very sad. How can we learn from COVID-19? What did Uganda do this time? We tried to copy the West. Admit and separate, that was what we said. Deny family visits or caring. Increase ICUs, increase the machines and put the patient into ICU. And many died alone in busy ICUs. Not a Ugandan way to die. You know, the Ugandans have their own way of dying. But African problems need African solutions. But they weren't given the chance because the people making decisions didn't know. Now, here is the population pyramid. And the population pyramid in Uganda is very different to the one in UK. Maybe UK would have less of a population if the people died as fast as they do in Uganda. And you can see the shape of it is completely different. The youngest are at the bottom and the oldest are at the top. And the oldest in Uganda are 2.38. And in UK, 18.46. We are 1/9 of the level of they are in UK. Okay, so, and all our children are under 50%. These are the other challenges that face us: the poverty, the economic insecurity. It's up and down. Success of medicine is only measured in cure more than in care, and life-limiting illnesses are not a priority. Not recognizing the need for a local solution, and recognition of valuing local creativity. The Ugandans are into doing things. They may not have been to university, but I'm telling you, they have the mind and the want to do so many things that we as Mzungus can't do. So we copied them. We copied UK. And we shouted, come to hospital, no relatives allowed, admitted on level of oxygen levels. We'll take your oxygen level. If it's low, you've got to come into hospital. But it's not just the oxygen level. Pandemics bring different and varied symptoms, and we never know which ones this patient has. We forgot that we had the best home care in Africa and Uganda for the last 28 years. We forgot about that. We said, no, let's get the technology in place. What did they want? They wanted to stay at home. They needed their families. They needed compassionate carers. They needed spiritual as well as medical support from the clinicians. What medics needed to know, and they didn't appear to know, was that oxygen levels go down in serious illness and dying. They even go down in an ambulance ride from home to hospital. Engage in patients in all social levels in decision making. Patient and family require total care, not just oxygen. So that had to be kept in mind. Is it home or hospital? Here's a patient at home. They could be outside or inside the house. But what happens in hospital? Is it hospitality? That's what the word means. Hospitality. Are you a guest in hospital? You're not. You're told what to do. You get into bed, put that thermometer in your mouth, put that oxygen test on your finger, and don't let your relatives near you. Okay, who's going to take you to the toilet? Who's going to wash you? This is a tradition here. We don't have enough nurses to do all that. And all this nurse is doing is answering the beep. Look at she's in panic. She's in absolute panic. So none of them are trained in helping somebody coming towards death. So here's the map of when Uganda was considered to be the best in Africa. Now, the deep green are the best type of palliative care. And you can see that it's mainly in the West and Australia and in Southeast Asia. But where is it? Where do we see it? It's here. It's only one country in Africa. That little tiny thing in the middle there, that ring, that is us. Okay, and we were the best. And that was from WHO and the World Hospice and Palliative Care Association in January 2014. It's gone down since. Why? It's gone down because we don't have the money. Now, this is a big man, Hippocrates, who made the Hippocratic Oath 460 years before Christ. Imagine, then they were still caring. And the Hippocratic Oath, and the two I want you to look at, it says, always do good, minimize harm. These are the two things that are so important. So wherever you come from, we have to concentrate on that, on this patient. But the other thing that we need is our ethos. This is the ethos of palliative care in Africa. And it's based on hospitality. Hospitality, where the patient is our guest. The patient is the same as me. I and the patient are one. We have the same bodies, and we need to learn from the patient. The patient and family are the center of all we do. And you can see here the patient and family are at the middle here of all we do. And the caring team needs to be supported at all time. Respect and support for sharing organizations is so essential, and it's one of the hardest things to do because we tend to rival each other and say, oh, I'm better than them. I'm more qualified than them. No, we're not. We all need to learn to live together, and we need to do our work with our patients in the context of the culture and of the economy of the country and the outcomes that are needed. We need to keep an eye on that and do research into outcomes so that the next time we're ready for them. What about the spiritual life? That is so important, but yet we're not trained in it at all. We are the ones that should be able to talk to them about spirituality, and they don't want all these different people coming in when they're dying. They attach themselves to the palliative care person. So that person has to be everybody. They have to be the social worker, the nurse, they have to be the occupational therapist, the physiotherapist, and the spiritual advisor. So here we see the symbols of peace for many, many religions. And on this side, we see the crucifixion, which we all know as Christians. But there's two bodies on this. There's the Christ crucified, there's Christ who rose again. And remember that each time that you control pain, that you relieve a symptom, that a patient walks again who's not walked for some time, when the family are happy and they have forgotten the pain because you have removed the pain with your morphine, that is a miracle. That to them is a resurrection. Suffering is not just the physical pain. It is the suffering of what's going to happen when I die, what's going to happen to my family, to my loved ones, who's going to pay school fees for the children, who's going to put bread on the table. And this man is dying, and you can see the suffering in his eyes. What do the patients want when life is suddenly limited? Suddenly limited. We don't have time to do all we need to do. Where does he want to be? Who does he want to be with? What carers does he need? What does his culture demand? What is his spiritual need at this special time? This needs to be thought of and planned before this all happens. Do we put him in quarantine? Do we ensure a care with the patient? Because you can't isolate him completely when he's so sick, he's weak, he needs assistance. Be prepared for any sudden changes. So they need a mobile phone around, and if they don't have one in the house, get the nearest neighbor who has one to help them. Investigations, most of them won't have them. They'll have to be diagnosed clinically by a very good clinician, and this is where we need them in palliative care. But we must learn from our patients, not our patients learn from us. Our patients have lived with their body all their lives. They know where the pain is. They know what is their suffering. They also know what medications help them and what make them ill. And this is so important that we are there and we listen to them. And so as we finish, let me just tell you that we need to be with our patients because they matter, because you matter, because you are you, not because you've got a broken leg, not because you've got cancer of this, that, and the other, and not because you've got COVID. You matter because you're you, and you matter to the end of your life. We will do all we can, not only to help you to die peacefully, but also to live every day with your family until you die, mainly at home. Thank you very much for listening.
Thank you, Dr. Merriman, Mama Merriman, the founder of Hospice Care in Uganda, and has trained many of us. She has reminded us that palliative care is total care. Uganda was at its best, and somehow this has been forgotten with the advent of COVID. We need to get back to caring for the people that have COVID. They are isolated, they are scared, they need compassion, they need spiritual care, and palliative care can indeed provide for this. The next presenter is also online, and it is going to be Cindy Sifros. Cindy is the Director of Education and Collaborative Partnerships, Hospice Foundation, and in addition to overseeing global partners in care partnerships, Cindy is also a fundraiser and a writer with extensive experience in raising friends and raising funds. She integrates traditional and emerging media to tell stories in a unique, engaging way. And Cindy received her BA from Indiana University and her MA from the University of Notre Dame. She has worked as a newspaper reporter, managing partner at an advertising agency, a director of creative services, a director of alumni affairs at Indiana University, South Bend, a director of advancement at an independent school, and an adjunct instructor at Purdue University and St. Mary of the Woods College. Please welcome Cindy Sifros.
My name is Cindy Sirfos, and I'm the Partnership Director for Global Partners in Care. Thank you for joining me today as I discuss strengthening access to cancer and palliative care through international collaborations. Global Partners in Care, which is also known as GPIC, was founded in 1999 to enhance access to palliative care, particularly in low-resource settings. We believe that palliative care should be available to all who need relief from pain and symptoms brought on by life-limiting conditions, including cancer. Ideally, this care provision will begin at the time of diagnosis and will continue for as long as needed. GPIC, which became an affiliate of the Hospice Foundation and Center for Hospice Care in 2017, is located in Mishawaka, Indiana. We are a nonprofit organization that has 35 partnerships that twin hospice and palliative care organizations in the U.S. with those in sub-Saharan Africa. Our African partners are located in 10 countries, and it includes 4 partnerships in Uganda. Our partners in sub-Saharan Africa range in size from small rural clinics to national associations that are charged with overseeing palliative care provision for their entire country. Center for Hospice Care has been a GPIC partner since 2008, and that partnership has given us firm grounding in partnership best practices. Our experience as partners has also helped us shape our partnership philosophy. We've found that one of the keys to successful partnerships is helping our partners shape relationships that are mutually beneficial. We've found that when partners engage in practices that are noted on this slide, their work as partners and as individual organizations benefits tremendously. Mutually beneficial partnerships are also stronger and more sustainable. We've learned that enhancing access to cancer and palliative care is a complex, ever-changing issue. By engaging stakeholders from multiple disciplines, from multiple sectors, and multiple backgrounds, we can increase opportunities for meaningful impact. For example, we know that palliative care is an important aspect of universal health coverage, but it must become more accessible. And this can only be achieved by engaging stakeholders at every level of the conversation. Those who have a passion for this work can come from almost any setting and almost any background. Collaboration that builds on successes that we have already achieved and moves forward strategically is key to increasing access to compassionate, skilled care for those that face life-limiting conditions. This includes collaborations with national and international palliative care organizations. This will help us increase access to hospice, palliative, and cancer care. We know that each organization brings a different perspective to the relationship, as well as different areas of expertise. When we work together to determine priorities, we can increase the impact of our work. One example of this that I would like to share today is the African Palliative Care Education Scholarship Fund for nurses and social workers. As part of our mission to expand the availability of hospice and palliative care in Africa and worldwide, Global Partners in Care and the African Palliative Care Association provide education scholarships for palliative care. Nurses and social workers in particular play an important role in providing holistic palliative care services to those suffering from life-limiting conditions, including cancer. Many African nursing and social work courses don't include training that exposes students to palliative care. Formal training in palliative care is greatly needed to provide nurses and social workers with the skills to handle patients with life-limiting conditions, such as HIV, AIDS, and cancer. These relationships have the greatest possibility for success when they are built with transparency and mutual respect in mind. One way in which Global Partners in Care helps facilitate successful partnerships and collaborations is to help partners and collaborators understand culturally and contextually appropriate cancer and palliative care. While many of the challenges that our partners and collaborators across the globe face are very similar, the way in which those challenges are addressed can vary greatly. We also know that we are stronger when we work together. When our partners and collaborators increase access to compassionate, appropriate palliative and cancer care, we have the greatest impact. This can be seen in tangible ways, such as increased capacity and an increased provision of resources for care. It can also be felt in intangible ways, perhaps most importantly, in the satisfaction that comes from working together to meet common goals and in gaining increased cultural competencies. So how are we able to measure the impact of our work? Certainly the intangible aspects are difficult to quantify. However, we are pleased to note that our partners have improved the quality of living for tens of thousands of people each year around the globe. In addition, U.S. partners have sent more than $6.5 million to support palliative care in Africa and in Asia. In closing, I'd like to note something that we feel strongly about, and that's the fact that while our partnerships and collaborations are between like-minded organizations, organizations truly don't work with organizations. It's people who work with people. And people are the ones who make the difference. As Gail Sykes notes in the quote that's seen on this slide, we see that we are all doing the same thing with the same heart. Thank you for all that you do to enhance access to palliative and cancer care across sub-Saharan Africa and around the globe. And thank you for your time today. Please contact me if you'd like to learn more about our work. My colleagues and I would be happy to share our successes, our challenges, and our work with you. Thanks again.
Thank you so much, Cindy, for that presentation. though it was recorded, but it's so clear and very good to us. I want to move to our last presentation, and you were hearing most participants were mentioning nursing, nursing, nursing. And I think that one is a key area as we provide services. Whatever kind of services we provide, nursing is a backbone. So our last presentation is going to be on nursing now in cancer and palliative care during the COVID-19 pandemic. And this is going to be presented to us by the head of the nursing, and that is Sister Beatrice Amuge. Sister Beatrice Amuge is an accomplished nurse. She grew up in the ranks from an assistant commissioner when she worked in Jinja Regional Referral Hospital, and later on she was transferred to Mulago National Referral Hospital, where she served for a long time before eventually being promoted to the position of Commissioner Nursing at the Ministry of Health Headquarters. She's in charge of nursing and midwifery services in the whole country. And she's a public health specialist, a researcher, and a member of the Institutional Review Commission from Makerere University, Kampala College of Health Sciences, and Mulago National Referral Hospital. Join me to welcome Sister Beatrice Amuge to make her presentation.
Thank you, Chair and Co-Chair, and the rest of you in the room. My topic is nursing now in cancer palliative care during COVID-19. When I was given this topic, I was actually very happy because it addresses what nursing now is talking about. Nursing now looks like it is a very new term and strategy in Uganda, but Nursing Now campaign is a global campaign which looks at raising the profile and building the status of nursing and midwifery in the country. Having realized that the nurses make almost 50% of the health workforce worldwide, and in Uganda it makes about 60%, and it delivers about 73% healthcare services. So globally, it was decided that it is very important to enable nurses and midwives to contribute in the delivery of universal healthcare coverage. And strengthening the nurses and the midwives has additional benefit of effective looking at the gender equity, contributing to economic development, and addressing some of the sustainable development goals. Nursing Now, when it was started in this country, allow me to talk about it because it looks like it's a new terminology. It was looking at year 2020. Year 2020 will make Florence Nightingale, the founder of modern nursing, to be 100 years old. So that year was blocked as a year of a nurse and a midwife. And the celebrations were supposed to have been there last year, but because of COVID-19 effects, the celebrations were pushed to this year because most of the activities were not handled. This campaign was launched in Uganda in 2018, and it has run up to this year, and it has evolved over time. After having looked at what the Nursing Now campaign is looking at, it was also decided that we need to add the element of leadership. And this year, the Nursing Now campaign changed to Nursing Now Challenge because of issues which have not been addressed. Now, Nursing Now campaign looks at nursing and midwifery practice, education, regulation, policy, leadership, and research. I am very happy when the previous speakers were talking, they talked about education, recognizing the work the nurses are doing and improving on their education. We also need to improve on their practice. We need to improve on the regulation and policy, leadership, and research. What are the strategies of Nursing Now campaign? Is to influence policy globally and also influence policy locally in the country to look at developing the status and the profile of the nurses. Now, actions of Nursing Now in cancer and palliative care during COVID-19 pandemic. First of all, I want to thank the Ministry of Health looking at the need to develop the profile of nurses in this COVID era. You see that the nurses are everywhere, even in the COVID cases. When you talk about the frontline health workers, you're actually talking about a majority being nurses. So Ministry of Health has gone extra mile to give the nurses the knowledge and skills so that they are able to deliver that care during this COVID-19 pandemic. So in COVID-19, in relation to cancer and palliative care, we need to advocate and build the profile of nurses. We are aware that the technology has changed and it's changing. The disease profile is changing. The way the care is supposed to be delivered is changing. And the majority of nurses, being the majority of healthcare workforce, usually use experience in delivering care. But Nursing Now campaign is saying we need to train them. We need to give them skills. We need to give them knowledge in cancer and in palliative care so that they are able to raise up their profile. They are able to be seen. And we need to establish and build strong partnership with the key stakeholders. That's why I was saying I was very happy that I was invited here. This is one way of building the partnership with the key stakeholders. We need to promote leadership pathways. Nursing Now campaign is looking at promoting the leadership pathway for nurses and midwives globally, but also in the house. And they should be able to advocate for the care of patients with cancer, for use of palliative care. And I'm aware that when you talk about palliative care, the nurses are the majority dealing with palliative care. Even the issue of community services, cancer as well as palliative care is in the community, but the majority of people who handle this are nurses. Create environment which should influence policy making. Nurses and midwives do a lot of care. They generate data. This data should be used as they deliver the care. As they are outside, they are 80%. Even the data they generate is very high. This data should be brought and it should be used for policy making. Develop the younger nurses to be leaders. We want nurses who are able to advocate for services, the nurses who are able to lead, the nurses who are able to talk with other key stakeholders. And then disseminate the evidence of good practice. Like I said, a majority of nurses actually deliver good practice, but with either experience or limited training This should be disseminated. This should be documented to increase their profile according to the aims and objectives of Nursing Now campaign. What are the outcomes of Nursing Now in the cancer palliative care during COVID-19? When you look at there is increased investment in nursing and midwifery workforce. Those are only nurses delivering that care, and we need to invest more so that they are able to do better services. Policy support for involving their roles. The roles of nurses today, like I said, there is a change in technology, change in disease pattern. Their roles are supposed to be changing so that they are able to match with a changing world. The nurses and midwives are visibility in decision making, available platforms for sharing knowledge and evidence for effectiveness, then other professional and community participating in nursing conferences and their evidence information. Nurses are supposed to be brought up because Nursing Now is actually looking at raising their profile. And how do we raise their profile? Is to make sure that they come and give, share the information in conferences, their evidence practice. In conclusion, nurses and midwives act as both individual members and coordinators. They bring people-centered care closer to the communities where they are needed most. When you look at it, the nurses only are not in the healthcare. The nurses are not only in hospital. They are in every health facility in this country and worldwide, and they're also in a community. So they take health services near the communities where they are needed most. They help improve health outcomes and overall cost effectiveness of the services. What are we saying? Let us invest in this big health workforce. Let us invest in the nurses and make sure that they contribute to the services in this country, including cancer and palliative care. Thank you so much for listening. Thank you.
Thank you, Sister Beatrice Samuge, for effectively helping us to wrap up this session in terms of the presentations. It has been important information, knowing about Nursing Now and its relevance even at a time like this, when we have to step up our palliative care and cancer care and yet contend with COVID-19. Again, what has been spoken about by other speakers, the training has to be stepped up, the enabling environment for policy making, the strong partnerships, which was also mentioned by your predecessor, the advocacy role. It was interesting that the nurses have to move out of the shadows, always being on the receiving end, and become advocates for better care and for the facilitation that will make them do this. And of course, in doing that also participate in disseminating good practice. Thank you very much for this that you have mentioned. Thank you. We have a number of people who are online, and we know that in attendance that have joined us in a number of groups. We have Ginger Regional Referral Hospital, where we have satellite attendees, people who have come together to listen and participate in this conference. We have Fort Portal Regional Referral Hospital. We have Soroti Regional Referral Hospital, Mbale Regional Referral Hospital, Lira Regional Referral Hospital, Hoima Regional Referral Hospital, Muvende Regional Referral Hospital, Mbara Regional Referral Hospital, and St. Francis Hospital in Zambia, Kagadi Hospital, and China-Uganda Friendship Hospital in Naguru. So you're all welcome, and you're all welcome to participate in the discussions after this. Chair, will we go through the questions?
Yeah. Maybe, thank you so much, my colleague. Thank you so much, my colleague. We have reached the time for question and answer, and we had 9 participants, presenters. But may I take this opportunity to invite Honorable Dr. Charles Ayume to come back on the podium. And Dr. Joyce, can you also join us, since we have only 2 more chairs, so that we open this presentation to discussion. Some of the questions has already been sent. Others are appreciations, which I want to request. My colleague will take on the issue of some questions, but others are remarks which the members have sent. The questions, we shall ask them. The first comment is from Lira Regional Referral Hospital, where they are thanking Honorable Dr. Charles Ayume. You have tackled almost all areas, especially the displacement of mental health services across all regional referral hospitals, which has caused a lot of relapses and increased new cases. So they are thanking you, Honorable. The other one is from Professor Dr. Aunt Merriman. She said, great to see a wonderful united conference 28 years after palliative care was introduced in Uganda. Thank you for having me on from CCU in St. Vincent's Teaching Hospital in Dublin. The next one is from Barbara Nakito. I wish the government appreciates and supports the palliative care, home-based care, as it has worked for the COVID-19 patient. Most of them are appreciation, and the other one is from Professor Julia. I thank Dr. Joyce. Such an important presentation on childhood cancer. We have to do all we can to care for our children in Uganda with cancer. The other one is from Barbara again. It is true, Ross. If you refer a child to Uganda Cancer Institute, most of them don't want to go. Even others run away from the hospital despite the counseling. So these are the comments which are coming in. May I invite my colleague, Dr. Andrew, to ask some of the few questions which are there. Then I bring in some of the other comments.
Thank you. Thank you, Dr. Mone. We have an overwhelming number of questions that have come in, and we have been advised that many of them can be taken on after, as we do online and through the online platforms. I will just pick 2 questions, and one is to the first panelists, Honorable Charles and Honorable Emmanuel, on the issue of functional palliative care policy frameworks. Many countries have initiated palliative care services, having benchmarked them here in Uganda, and have gone on to have functional palliative care policies. And examples are given of Swaziland, of Rwanda, Botswana. Every other conference, we are reassured that the policy is soon being approved, only to have another vicious cycle 2 years on. Next conference, when the policy is still not approved, please, how soon is soon? What is the tall cliff standing in the way of this policy for palliative care and the right to the relief of health-related suffering? I will allow Honorable Charles and Dr. Luirika to make very quick responses to this. Please go ahead.
Did we switch it on? It's on. Thank you very much. Good enough we have a representation from the Ministry of Health. Not all hope is lost. It's not that we are starting from scratch. The policy is at ministerial level, and I'm sure when the minister brings it to Parliament, we shall be able to synergize and push it forward. Thank you.
Thank you for that very quick answer.
Yeah, thank you so much. Maybe to add to what Honorable Dr. Charles said is the policy development is a responsibility of the Ministry of Health, and at many occasions the Ministry of Health has explained why it has delayed. But right now, as we talk, the family of palliative care last met in Entebbe and have finalized on the policy. What now remains is to develop the regulatory impact assessment. As you know, when we practice palliative care, we have a lot of anti-narcotic drugs that we use, including morphine. And it touches something to do with the Ministry of Internal Affairs. So we are going to have the regulatory impact assessment, and once we have finished that, as the Honorable said, it will again be tabled to the Cabinet and then to Parliament for approval. But we have gone to a very high level of finalizing the functionalization of that policy. Thank you.
Dr. Mone, thank you for that. I don't know whether Dr. Lyrica, do you have anything else to add to it? Probably from a continental perspective as well.
Thank you very much, Chair. I just want to also appeal that we expedite that process, because Uganda was one of the first countries to start, and therefore we need to move, because if you look at the countries that began after Uganda, Botswana did it in about 14 months, Rwanda in less than a year, Swaziland. So I agree that we as Dr. Mone has said, that we move fast now and ensure that before a lot of time elapses, we have the Ugandan one in place.
Thank you.
Thank you very much.
In the converse, what are they doing right so that we benchmark them as well?
I think maybe it's the different processes that we follow. Some of the countries have, by the time we go into the process, the policy-making process, they know what they want. For example, Botswana, one of the main things that was disturbing them is the policy to provide a framework for them to support hospices and other non-government providers where government doesn't have a facility. The moment that appeared in the policy, they could easily pass the policy, because much of the money that you need to implement the policy is already being spent by government. For example, the facilities are already there, the medicines are already there. Maybe you need some extra staff, but you're not going to build in new buildings. You are still using the same buildings. I think for them, they use that method and say, we already have the infrastructure, maybe we need some few staff, we already have the medicines, let's go ahead and then add on things as we go along.
Thank you for that. Thank you. I'll very quickly move on to the last question, and this is from Agasha Birungi, who is asking, reflecting on this conference, I'm happy and I'm optimistic about the future. Great strides and magnificent achievements in cancer and palliative care separately. How do we increase the level of collaboration between the two, that's between cancer and palliative care, so that they grow together? So that we reduce the risk of one growing faster than the other. My question goes to Dr. Balagade and to Dr. Luirika.
I'm informed that we are time bad.
All right.
We will share these questions, and we respect our colleague from Uganda Cancer Institute and our colleague from the African Palliative Care Association to answer those questions and share with us. Otherwise, we want to appreciate so much the participants, both in the House and those who are attending to us virtually. Maybe we could give one opportunity to one of the panelists to make a closing remarks before we bring this session to an end. Honorable Dr. Charles, may you give us a closing remark on behalf of the participants?
Thank you very much. One is more of a thank you for the organizers of this very important activity. I'm quite impressed by the multi-sectoral turn-up, and it was well thought through. The invitation cuts across the board, and I think that's the way we should approach some of these things. We should not operate in silos. I am a pupil of interdisciplinary and multi-sectoral approach, and I think that's the way to go. We should not look at palliative care as to piggyback on cancer. There are very many other aspects that need palliative care, palliative therapy. So let us try and plow it into routine health service delivery. That also goes back to training. We should not have nurses. I think in nurse training school, Madam Commissioner, I think it's very important that nurses are able to handle at least basic palliative care, because we are seeing a lot of it being mismanaged. Immediately there's a case where you suspect palliative care, you just write on the consultation request form for hospice to review. But I think it should gravitate to as low as Health Center 4, Health Center 3. Parish model is coming up. What are our thoughts on integrating it into the parish model? Healthcare is a very important role. We saw HIV 20 years ago when it was looked at as something very alien, very foreign, and up there for high-level scientists. But then with task shifting, we saw it gravitate to clinic officers, to nurses, to midwives, and we have really done well as a country in terms of HIV/AIDS. So I think in terms of cancer, Dr. Riem, I think we should also think of doing some level of task shifting and getting it into training institutions, palliative care, and I think we shall be able to make huge strides in terms of palliative care and management of cancer. It is multi-sectoral. We can't run away from it. There's a preventive arm. There are legal frameworks. And I'm very glad that there's good interface with Parliament. Please do not leave us behind. You have a lot of capacity building to do, because we're the highest decision-making organ in the land in terms of laws and policies. So it's best that we speak from an informed perspective. I thank you very much for all those who have turned up, and those out there who have managed to log in and made some substantive contributions, and the organizers of this conference. Thank you very much.
On behalf of the two of us who had been chairing this session, we want to say thank you so much for being very good audience. It has been a long session, but I'm sure you must have learned a lot, and we want to bring this session to a close. Thank you so much. Thank you, organizers, for these very important steps that you have taken in bringing the cancer and palliative services known to the people and taking it closer to the population. Thank you so much, and that is the end of our session. Thank you.
The Pikau Goodwill Ambassador. I'm here to inform you that Uganda Cancer Institute, together with the Palliative Care Association of Uganda, in partnership with the Ministry of Health, will host the 3rd Uganda Conference on Cancer and Palliative Care on 23rd and 24th September 2021. The theme of the conference is Cancer and Palliative Care in COVID-19 and Other Challenging Situations. This year's conference is a unique one and will be held virtually, with some sessions broadcast live on UBC TV. We will have panel discussions, plenary sessions, and workshops, as well as presentations of abstract where scientists will share latest research on cancer and palliative care. This conference will bring together at least 400 policymakers, researchers, health providers, patients, and the general public who will be watching online. I encourage you all to register for this important event. Registration for Ugandan delegates is 200,000 shillings.
For more information, call 0392 080 713 or 0414 540 410. Email conference@uci.or.uj or conference@pcau.org.uj.
Echa COVID-19 chijja kugwa only if we stay at home, observe physical distancing, wear masks properly, sanitize or wash our hands with soap and water regularly, or get vaccinated now.